Okay, so we're just having a few people sign in. Let's get the chat open so we can have a bit of a chit chat. Here we go. So hi everyone, my name is Dr. Lasker. I'm a consultant radiologist. Thank you so much for joining us. We're doing this video, this webinar on behalf of radiologyseminars.co.uk. If possible, could I just get a few yeses, nos? Can you guys see me? Can you hear me? Can we get a few yeses? Great, good. So yeah, welcome. I'm really so grateful that so many people have signed up. So many people have come to this particular talk today. Yeah, like I said, my name is Dr. Lasker. I'm a consultant radiologist, and we're doing this free Zoom webinar on the neglected abdominal X-ray. You'll find that a lot of the time, abdominal X-ray is kind of pushed to the side. People don't really pay attention to it. It's more of a step towards getting a CT, and a lot of people have kind of left it to the side a bit over the years. And so we thought it'd be a good idea just to try and revive it a bit, try and get people to maybe pay attention to the abdominal X-ray, because there are a few times when you can actually see a fair bit. And we've been, it's a real pleasure to welcome Dr. Asif Naleem, who's a consultant GI radiologist at Basildon Hospital, UK. And he'll be doing this, the next talk, going through a few cases. Now, a bit of a treat for everyone. I hope this is a treat anyway. I'm going to put a link up on the screen in just a second. It is, oh, hang on. I want everyone to be able to go through the cases at the same time as us. And so what I've done is actually upload all the cases that Dr. Naleem is going to be going through during this talk so that you guys can actually have a look at it yourselves in real time. And that is going to be coming up in the chat in just a second. Okay, so hopefully everyone, oh, that's going to go to all attendees. This is the link, it's in the chat. So that's your link to be able to access every single case that we're going through. And I'm just going to quickly share how we're going to go about doing this. If I share this one, this link will take you to this page that you're seeing right now. And I've got a question. Oh, good, thank you. So yeah, this is the page that you've got. This will have every single case that we'll be going through. All you have to do is click on number 1. It will open a new window, and then that case should upload for you. Once it's uploaded, it works exactly like any other Daikon viewer. You should be able to zoom, pan, all those things that you may be wanting to do to be able to have a feel about what's really going on and what Dr. Naleem is talking about. My computer's being a little bit slow, but that should work. Oh, here we go. It's coming up in just a second. So this is a full Daikon viewer that you'll be able to sort of play around, and you will be able to access this talk afterwards and be able to access these cases using the link that I have left on the screen for you guys. So yeah, please feel free to take part in what we're doing as well. So without much further ado, I'm going to hand over to Dr. Asif Naleem, who will be taking the rest of.
Okay, so let's get straight to it. My name is Asif Naleem. I'm a GI radiologist at Basildon and Thurrock Hospital. So diving straight in, the neglected abdominal X-ray. So let's start with a little bit of anatomy. So first, let's have a look at the stripes. So there are two approaches of looking at an abdominal film. The first one is lines and stripes. A stripe is effectively a way of saying a line or an edge in the abdomen, usually formed between an interface between fat and muscle in the normal abdomen. In the abnormal abdomen, other things such as air and fluid can contribute to the stripes. The things I've drawn out here, you've got your properitoneal fat stripe there on both sides. That's effectively just a vertical stripe at the lateral edge of the film. It's a layer of fat deep to the transversalis fascia, which is a thin aponeurotic membrane at the inner surface of the transversus abdominis muscle of the abdominal wall. That's one fat stripe we can see. The other thing I've drawn in red is the psoas muscle shadow, which is a stripe formed by the interface between the muscle and the retroperitoneal fat. Now, technically, all of the other organs, particularly the retroperitoneal organs, will form stripes where you can see their outline between the organ and the fat, such as the left kidney here. These are seen to varying degrees depending on the amount of intra-abdominal fat with the patient. Now, lines I don't find particularly helpful, to be honest, apart from looking for things such as symmetry. What I find more useful is the second approach, which is the Quadrance approach. So looking at quadrants is a useful system as clinicians use this to examine the abdomen, and therefore it's how they come up with a differential. So if we start with the right upper quadrant, the things that you would expect here, the structures you would expect, you've got the right lung base, you've got the liver, you expect the adrenal to sit somewhere in here, and you want the right kidney there. Also, you'd expect the head of pancreas to make an appearance somewhere around there. The left upper quadrant, similarly, you've got the left lung base, you've got the spleen, the left adrenal, the left kidney somewhere here. You can see the shadow there. And you'd expect the tail of the pancreas to come in just to the left of the midline. Right iliac fossa, you'd get the appendix and the cecum, the right adnexa in case of a female. Left iliac fossa, you've got the sigmoid colon and left adnexa in the case of a female. And then after that, you've got other structures that would normally cross multiple quadrants, which is the small bowel, which tends to be positioned centrally, the large bowel, which tends to form a way all the way around the outside of the abdomen, forming a sort of a rectangular shape. And you've got the abdominal aorta and the spine that run through the midline vertically. So that's pretty much the anatomy that we would use. Let's dive straight into the cases. So hopefully you're able to view these cases and scrutinize them all on your own, as Imran said. But if not, don't worry, we'll run through them together on the PowerPoint as we go along. So the first case is what we would effectively call a normal abdomen, normal in inverted commas. You can see here you've got a heavily calcified aorta due to atherosclerotic disease. You might also notice in both upper quadrants, you've got calcified pleural plaques. But apart from that, the lines and stripes are all symmetrical. You've got a normal bowel gas pattern. So for the purposes of an acute abdominal film, this is a normal study apart from what we've just described. So let's move straight on to the next case, case 2. So part 2 is where, having gone through the anatomy, we're going to run through a series of cases to do with the bowel. So the main reason that the vast majority of work with the abdominal X-ray is to do with bowel obstruction or suspected bowel obstruction. So having a look at this case, the first thing that we can see is several dilated loops of small bowel, centrally positioned, air-filled. So when we talk dilated bowel, we use something called the 369 rule, which you might have heard, which effectively is 3 centimeters for the small bowel, 6 centimeters for the large bowel, and 9 centimeters for the cecum. Now, when looking at bowel, try not to break out the ruler. Try more to look at the pattern of the bowel. So if you think of the bowel as a continuous tube, a pipe that's going all the way through from the mouth to the anus, and almost a drain pipe. And whenever it's blocked, you'd expect everything above the blockage to dilate and everything below the blockage to decompress. So as you can see on this film, you've got a blockage somewhere in this region. Of note, you've not got much in the way of air in the large bowel. You've got a little bit of air in a decompressed ascending colon there. We're not seeing any air in the left colon or in the rectum, which is conspicuous by its absence. So this is a classical presentation of small bowel, a classical appearance of small bowel obstruction. This is what the CT showed. So you've got multiple dilated loops of small bowel, which is what we saw. And this is the level of the obstruction, and it was due to ileo-ileal intussusception, where the bowel telescoping into itself. And that's why, again, we saw this there. You've got a few flecks of air in a collapsed colon, but small bowel, so mid-small bowel obstruction. So that's bread and butter for small bowel obstruction. So let's move on to the next case. We'll give everyone a few minutes to have a look at this. When I say a few minutes, maybe about 20 or 30 seconds. So again, I'll start to talk. The most conspicuous thing we can see here is a dilated loop of large bowel. You can see large bowel, it's not got where, it's far bigger than you would expect. It's positioned towards the periphery of the abdomen, and it's got haustral markings as opposed to the smaller, finer valvulae conniventes that you see with small bowel. Now, what you see with this x-ray is you've got an isolated loop of large bowel. That's all I can see. Corresponds to where I would expect the cecum to be, or the ascending colon, and I'm not seeing much air in the large bowel beyond that. So I'm suspecting a proximal large bowel obstruction here. Now, if it was a distal large bowel obstruction, as we've said with our drain pipe analogy, I see no reason why all of this large bowel here wouldn't dilate out and be fluid filled or air filled. The fact that we're not seeing anything in that region makes me worry about a blockage somewhere in this region. Looking at the CT, it was slightly higher than we saw there. That's what we're seeing on the plain film, the dilated loop of large bowel. And the obstruction is there. It's at the level of the mid-transverse colon, and you've got a tumor causing that. So the reason we're not seeing that on the plain film is sometimes you can have slightly dilated bowel, which is fluid-filled. You won't always see the fluid-filled part of the bowel. You'll see the air-filled, but the fluid-filled can sometimes be obscured by other structures. So moving swiftly on to the next case. Again, I'll give you about 20 seconds or so, to 20 to 30 seconds to have a look at this. So again, the thing I'm noticing most on this particular film is you've got dilated large bowel. As far as the distal descending or proximal sigmoid, got the impression of a soft tissue abnormality or density, because you've got a fairly abrupt cutoff point at this level, but I wouldn't overcall that based on the plain film on its own. What I would say is you've got dilated large bowel extending all the way around, and I can't trace it beyond the proximal sigmoid, and you've got some dilated loops of small bowel centrally. So I'm suspecting large bowel obstruction on this film. Having a look at the CT, that's effectively what you're seeing. You're seeing this mass invading the proximal sigmoid, causing dilatation of all the large bowel peripherally, and that backs up the small bowel, which is also fluid-filled and dilated centrally. So that's what we're seeing there. So that's a distal large bowel obstruction. The difference between the two films, when you have a look at it, is when you can see that on the previous one you only had the ascending colon that you could see, and on this one, on the second one, you had the entire colon that was dilated out. Just to go back quickly, the proximal large bowel obstruction, you're only seeing the ascending colon dilated, and on the distal large bowel obstruction, you're seeing most of the colon with backing up all the way through into the small bowel, as you would expect. So 20 seconds on case 5 now, if everyone can just click on that. And again, this whole section is to do with bowel, so mainly concentrate on the bowel if you can. We've got an aortic endoluminal graft in situ there, which you can ignore for this case. So having a look at this case, what you've got is you've got this structure here that is commonly described as a coffee bean. Once you say coffee bean, that immediately is synonymous with a sigmoid volvulus. This is a similar thing that you see on CT. This is effectively the dilated sigmoid, which is coming out of the pelvis, reaching all the way up to the epigastrium before looping back down, and the twist being somewhere in the pelvis there. So that's a classical appearance of a sigmoid volvulus. Again, moving swiftly on. You've seen this before. This is similar to case 2. Now, you've got multiple loops of dilated small bowel, centrally positioned. This is small bowel obstruction. We can call that there. Now, the interesting thing with this case is we did the CT for this, and there was no transition point on the CT. And this patient has had multiple previous surgeries. So this was diagnosed on CT as small bowel obstruction secondary to adhesions. So what often happens then, you'll see, is you do a gastrographin follow-through. So this is what the gastrographin follow-through looked like after we gave oral gastrographin to drink. This is how the film looked at 4 hours. Now, what you can see here is you've got multiple loops of dilated small bowel that are opacified with gastrographin. You've got air fluid levels within the small bowel. So this is still looking like obstruction. Importantly, what you're looking for with a gastrographin follow-through is you're looking for the oral contrast to progress all the way through into the large bowel. And I can't see any evidence of this progressing through. If it was, you wouldn't expect to see it held up within the dilated small bowel with these air fluid levels. So what happened with this film is we sat on the patient. Another 4 to 6 hours later, a second film was taken. And as you can see, that small bowel obstruction has now completely resolved. The gastrographin is sometimes therapeutic in terms of it can be used to test the obstruction, and sometimes it will resolve based on the gastrographin alone. As you can see here, the dilated fluid-filled loops of small bowel have resolved. All of that contrast has passed into the large bowel, and it can be tracked beautifully all the way through the colon into the rectum. So that's what you're looking to see with the gastrographin follow-through. Now, if that doesn't happen, and if on a delayed film or a repeated delayed film, that continues to look like that, then you've got to start talking about potentially surgically intervening, because that's not resolving. But often when you do these films, particularly with adhesions, you would expect to see that at some point that would open up and you'd see the flood of contrast into the large bowel. And that's one of the main uses of abdominal film nowadays, in terms of you can see a single snapshot of the abdomen over periods in time. So at 4 hours, at 6 hours, at 8 hours, and you can see how contrast is progressing through the bowel. And it's a much lower dose than having to do repeated CTs, which to assess for progress. So on to the next case. Again, we'll go through this one slightly more quickly because we've got a lot of cases to go through. So in this case, the main abnormality you're seeing is the transverse colon. You've lost that normal, beautiful horse trough pattern, and you're seeing thickening of the bowel wall there. Almost what you would describe at the proximal transverse colon as thumbprinting. Once you say thumbprinting, that's synonymous with inflammatory bowel disease. In this case, Crohn's, you can see submucosal edema within the proximal small bowel, causing that thumbprinting appearance that we had on the previous radiograph. So an abnormal bowel gas pattern isn't always dilated bowel. Sometimes you have to be aware of thumbprinting, where you've got inflammatory bowel disease. Other type of abnormal bowel gas patterns, I'll give you 20 seconds on this film just to have a close look. But importantly, when looking at bowel, you're not only looking at the bowel gas pattern within the bowel, you also want to keep a close eye, particularly in the acute abdomen, for whether there's any bowel gas outside the abdomen. And in this film, you can see what is a classical Wriggler's sign. When you have a look, you can see bowel gas or air on both sides of the abdomen, of the bowel wall, giving you a beautiful stripe of bowel that you can see perfectly there. Same patient on the plain film. On the erect chest x-ray, it's unequivocal on the chest x-ray. You've got large volume air beneath the diaphragms on both sides. Again, you can see air outlining the fissures, outlining several bowel loops on both sides. pneumoperitoneum. So it's not only the air within the bowel, you're also keeping an eye on air outside the bowel. And it's not only air that comes outside the bowel, it's also fluid and other structures. So on this film, you can see, do you remember those properitoneal stripes and those psoas stripes that we showed on the initial anatomy? They're completely lost. You've got a few loops of air-filled bowel that almost seem to be floating in greyness, homogeneous greyness throughout the abdomen. So the stripes are as conspicuous in their absence, sometimes more so than when they're present on the film. And in this case, we've lost the stripes because you've got large volume ascites, which is completely obscuring all the fat planes. And that's why you have this large grayness throughout the abdomen, which is causing this appearance. So we slightly rushed through that, but that's the predominant. Those are most of the bowel cases, and bowel is the main reason why we would be doing an abdominal X-ray. But there are a lot of other things that you will see incidentally on a plain film that we've almost lost the art of looking for due to over-reliance on CT. So these cases you might find a little bit more interesting. So I'll give you a few seconds on case 10. Now, as I said, with the stripes, it's important to look for their absence as much as their presence. Also, when it comes to bowel gas pattern, you want to look for absence of bowel gas as much as its presence. So this structure here, that's the stomach. And it's quite an abnormal configuration because normally you would expect that stomach to come across through here. Whereas it almost looks as if it's being pushed all the way round. And interestingly, all the bowel, you can see air-filled bowel within the rest of the abdomen, but there is absolutely no air or no bowel projected over this area of the abdomen. Now, using our quadrance method, this is the right upper quadrant. So the structures that are in there, you've got the right kidney, the liver, the pancreas, the head of the pancreas, and the adrenal. So you're worried about a mass or a space-occupying lesion that is pushing the bowel over to the side. And when you have a look at the CT, you can see hepatomegaly due to multiple liver metastases, pushing the compressed stomach all the way to the left. And that's what's causing our absence of bowel gas in this area. Moving on to case 11. Again, I'll give you 20 seconds or so at that film. So the primary abnormality I'm seeing on this film, when we have a look at it, is you've got a few calcifications within, I would say, just about the right upper quadrant, but almost somewhere at the interface of the right upper quadrant and right lower quadrant. Again, you've got some irregular calcification, and of note, there's an absence of bowel gas within this area. Again, within the right upper quadrant. So that's making me worried about a mass, again, within the right upper quadrant. So as I said before, our structures within the right upper quadrant are our liver, pancreas, head of pancreas, and kidney. But we've got some stripes preserved here. That's the fat stripe with the caudal surface of the liver. So that liver looks relatively normal. So I'd be worried about the kidney as being the structure that sits immediately below the kidney there. And I'd be worried about a renal mass. And looking at the CT, you can see a large soft tissue density mass with focal calcification. Again, the bowel is displaced from this area, which is why you're getting that pattern of displacement of bowel gas and calcification within a renal cancer. Moving on to case 12. Again, I'll give you about 10 seconds on this. We'll try and do this one a little bit more quickly. So this is a little bit more subtle. Can you see right across there? You've got some calcifications there. Let me get rid of that. Got some a few speckled calcifications at the top. Almost if you window it carefully on your viewer, they're crossing the midline. So what sits in the epigastrium or spanning both right upper quadrant and lower quadrant, crossing the midline, that's where we'd expect the pancreas to be. And having a look at the CT, this is just chronic pancreatitis. You've got speckled calcification throughout the gland, crossing the midline. Sometimes have to window that quite carefully, particularly when it's fine or fine calcification, but that's just a chronic pancreatitis. Similarly, we'll try and do this one quickly. 10 seconds or so on this case. So this is nice and easy. This is, it should be a 10-second film. That's what we're looking at. Again, a calcification. You can see a beautiful renal outline there as the left kidney is enveloped in the left perirenal fat. All of your other lines and stripes are preserved. Normal bowel gas pattern. That's a left renal lower pole calculus. That's so classical, we didn't even take a CT to confirm that. So again, moving quickly on to the next case, case 14. Just take a few seconds on this. There's more than one pathology on here. So having a look at the case, the obvious pathology is this dilated loop of transverse colon, which cannot be traced beyond the splenic flexure. Now, on the CT, that just happened to be pseudo-obstruction, nothing to worry about. But did anyone else manage to pick out this thing here in the left upper quadrant? And going back to the plain film, again, what catches the eye is the dilated loop of transverse colon. Again, you can see here, you've got a calcified, shrunken spleen in the left upper quadrant. So this is a case of autosplenectomy in a sickle cell patient, calcified, densely calcified, shrunken spleen. So again, as you'll see, most of what we're having a look at is calcifications because they're the things that jump out within the abdomen against the normal soft tissue structures. You don't have as much contrast resolution as you would get in a CT to delineate in the absence of fat surrounding the structures causing lines and stripes. So again, on this film, you'll see a lot more calcifications, and again, the obvious abnormality are these calcified structures here, which correspond to benign calcified lymph nodes, probably secondary to previous granulomatous disease. But when there's an obvious abnormality or something that catches the eye of the film, the important thing is to scrutinize the rest of the film closely, going either across our stripes or through our four quadrants, looking at the normal structures we would expect in each. And if you had done that, you might have seen this thing coming down here, the calcified rim of an abdominal aortic aneurysm. Nicely seen on CT here. You've got the calcified mesenteric lymph nodes in the right lower quadrant and the corresponding dilated rim calcified abdominal aortic aneurysm, giving that pattern on this film. So always go through your processes, always make sure that you look through all your lines and stripes, and again, you scrutinize all the quadrants just to make sure that you're not missing anything when scrutinizing these films. So again, we'll give you another 20 seconds or so on this film just to have a look at the case. Now, the obvious abnormality you can see on the plain film here is a large rounded calcified structure within the pelvis centrally. Now, there are not many things that sit here that could either be related to bowel within the pelvis, but it's difficult to think how. It can be a calcified cyst, a calcified fibroid. That would be my top differential for something within here. And if you'd scrutinize the rest of the film, seen another calcified structure, hopefully in the right upper quadrant. And again, the structures that live there, you've got the kidney, that could either be a renal calcification or more commonly a gallstone. So looking at it on CT, this did actually correspond to a small benign calcified uterine fibroid. The right upper quadrant calcification corresponds to a impacted stone at the neck of the gallbladder. So now going on to some more interesting calcifications. So we'll give you about 20 seconds on that just to have a close look and maybe formulate a differential or so again, we'll start with our negatives. The bowel gas pattern looks to be completely normal, not dilated. The most striking abnormality, as most of you would have picked up, no prizes for picking the massive calcification throughout the central pelvis and predominantly within the left lower quadrant here, although you get the impression of a mass which isn't calcified within the right lower quadrant as well. So this is involving predominantly the right and left lower quadrants. When we have a look at the CT, you can see that this is a grossly enlarged multifibroid uterus, which is coming out of the pelvis, displacing all the bowel upward. And that's what's giving rise to those appearances. So again, another interesting plain film we've got from our collection. I'll give you about 10 seconds on this. So again, starting with negatives, which you normally wouldn't do, but just to give you a chance to get your eye on the abnormality. You've got lots of normal looking bowel, small and large bowel, which seems to be displaced by this large oval structure arising from out of the pelvis. Now, there are not a lot of things that can sit there. Main differentials or main structures that sit within the central pelvis, you're looking at your uterus. If it's a female, an ovarian cyst, again in the case of a female. Otherwise, the urinary bladder, which can sometimes distend quite significantly. In this case, the patient was a male, and the structure in question is a large, grossly distended urinary bladder, secondary to bladder outflow obstruction due to prostatomegaly. So finally, that's a whole series of abdominal plain films we've gone through. We'll have a look at the last film. Now, whenever you have a look at an abdominal film, on top of the bowel and the organs, you get the axial skeleton for free. Every abdominal film is in effect, at least partly, a radiograph of the pelvis and the spine. And if you window carefully this film on your viewer, you might have noticed that when you look at the bones, you've got pedicle, 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 and going up pedicle at T12, and it's absent on the left. And when we had a look at the CT, See, that corresponded to a bony metastasis at T12. So always very important, scrutinize the bones, particularly the pedicles, looking for bony metastases, classical appearance where you can get destruction of the pedicle. And as we can see, an MRI spine showed replacement of the normal bone marrow, causing destruction of the pedicle on the left. And that's giving rise to the loss of the normal beak-like appearance of the pedicle. So that was a bit of a steam train through lots and lots of abdominal cases. Any questions with any of that? Imran, do we have anything?
Doesn't look like it. I think we have done. Please repeat the first slide of the anatomy. I don't think we'll repeat the first slide of the anatomy. We've got recording that will be going out later, straight after. I mean, once recording gets done by Zoom, it will be going out to you guys, so you'll be able to access that. So don't worry about that. So thank you so much for turning up for this talk today. I really appreciate it. I'm just going to finish off with what I'd like you all to do, if possible. I'm going to ask you, if possible, could you please click on the link that I'm leaving in the chat right now and just give us some feedback, because we all like to do teaching. Asif likes to do teaching. Dr. Said also likes to do a lot of teaching and stuff. So it'd be really great if you guys can give us a bit of feedback as to how you felt the session went. Dr. Naleem is going to be doing. So what's ended up happening is that Dr. Naleem is actually doing a CT colon course, but that got fully booked. And so because of that being so fully booked, we decided to bring him back again. And Dr. Naleem has kindly said that he will be happy to do another talk for us. It's steadily becoming the go-to course of CT colonoscopies for radiographers. So, you know, hopefully I think it'd be really great if you do turn up, if you're at all interested in colonoscopy. Please do feel like, please have a look at the website and try and sign up if possible. We try and keep it as accessible to everyone as possible. We're always available on our website, via email, etc. So please feel free to email us if you've got any questions, any suggestions for any future courses, any future webinars. Also, we've got all these other courses that are coming up: chest X-ray, advanced X-ray, MRI knees. We've got so many things coming up. Just try and make sure that everyone is being able to read the scans that they are working with every single day. So thank you so much. Thank you, Dr. Naleem, for turning up today. Really appreciate it.